I was told that this has to be something which is an overview of what is there to introduce you to what has been done in the last 2 to 3 decades in this field. As medicine gets more and more complex, more and more specialized, more and more technologically advanced, and we'll get into all that. So some areas, unfortunately, we have to get a little technical. I'll try not to dwell on them a lot. In some areas, we will be quite intuitively obvious, and some areas we'll have some fun. So between all that, we'll try and finish the talk in a way that you should hopefully enjoy it. There is a lot of videos and all in there, and that is the idea that we try and make it easier for you. As we say, one video, one picture is worth a million words. So what are we going to talk about today? Well, today we're talking of the state of, briefly we start with the state of pulmonology of the last 4 decades as seen through my eyes, which are either fair or biased. I hope it's fair. Then I'll talk of the renaissance which has hit the field of interventional pulmonology. And then we'll talk of the scope of this field, what all is there out there. I will have to give some data, and that is where, bear with me if I push you into some aspects of sleep over there, but we'll try and make it interesting. And then we'll tell you what we can do in India, that we are now talked of being people who don't do a lot of research and don't put our work out. Is there something more we can do? Because ultimately, modern medical aims are not only just clinical care, it's a lot beyond that also. A word of caution, nothing is rosy everywhere. It's always fraught with some risks, some dangers and some worries which we have to take into consideration, and we'll summarize the whole talk after that. So white paper of pulmonology, this field for 4 decades. What were we? We started off as TB doctors. The whole initial part is TB doctors, sanatoria, tuberculosis was rampant, and understand that most of whatever we have has come from the Western world. So if the Western world had TB, they dealt with more with TB. Then they were called TB doctors. The Western world very smartly and brilliantly, by and large, got rid of TB, and they shed the label. We took on that label, and we're doing it in every aspect of life, as you can see. Whatever is westernized will ultimately come here, and we love it, and we tend to take it on. So that is what happened, and we became TB doctors. In fact, to the condition that we still are called TB doctors in many parts of India, and that is both reminiscent of our past, but tragic when it comes to the fact that it undermines the whole field in a big way. Then over time, the whole epidemic of asthma and COPD came, pollution started to increase, there was overcrowding and so on. And so we were promoted to asthma COPD doctors in addition, and there we stopped. And that is why my whole talk was titled as Beyond TB, Asthma and COPD, because things have happened beyond that. Then ultimately what happened, CT scan came. The moment CT scan came, the whole 2 big huge lungs with 6 million alveoli, airways, mediastinum opened up. We realized that it's not only basically Apollo, it's Apollo with 25 different branches of Apollo. Medical schools, hospitals, private hospitals, home care, labs, everything opened up. So we began to realize the field much better and realize not everything is TB. That the original, the famous phrase that the eye does not see what the mind does not know, the mind started to know more, so I got better and better at seeing stuff. And then came the quandary that we actually got into the realm of what's called, my God, we got to diagnose patients. And your dean was just telling me that. And we suddenly realized, no, I cannot just use professorial or eminence-based medicine, which is me standing here, talking in a confident voice at 60 to 70 decibels, looking at you in the eye, and you being in a position of learning, and that word junior in India is very common, you got to listen to me. And you will walk out with whatever knowledge I give you. And as they say that, unfortunately, that may not be the right thing because you haven't actually done the job. It is like swallowing a morsel chewed by somebody else. And that is what was going on for many years. And now we decided that diagnostic and by extension therapeutic dilemma started to increase. So over there, we now realize that we were doing limited workup. We should probably be doing workup more before labeling people as diagnosis. Our mindset is a physician mindset, that we tend to examine, look, test, and make a conclusion. Beyond that, invasive testing is a very minor part of what we do. Invasive diagnostic testing was not part of the average physician's DNA. And then came the fact that Indian spectra are horrible. We see early, we see mid, and a lot of it we see late. And so when we see late, we really don't know how bad it is. We see how bad it is, but we really don't know what to do with it, and becomes even more challenging to put it through procedures. And technology came very slow to us. It first hit the Western world, then it hits the fields which make money, unfortunately. So cardiology, gastroenterology, cardiac surgery, somewhere laparoscopic, neurosciences, then gastroenterology, then vascular, and finally the same pretty much the same principles hit the field of pulmonology. So it was late to catch up over here, and that is why we had a high level of, not bad, what was going on that time, my opinion, my experience. So keen, wonderful, experienced people put their best on the table. But the question was that good enough or no, or was time going to tell us that things are going to change? So this was the field for 4 decades. This is the background we create to tell you what is happening now. So when it comes to pulmonology, 1892, somebody described the nasal douche and nasal lavage. Brilliant fellow actually, it still works very well now. But it was that time, and that was probably the only procedure we knew, short of actually putting some drastic tubes or somebody into people, and we stayed here for a long time. We did not move at all until we have this whole paradigm, the changing status of the field, what happened in the last 2 to 3 decades. So what happened in the background? There was noise going in the background which ultimately came to the forefront. One, pulmonology became important. There was a tremendous need due to increasing burden of respiratory disease. And why was there? Well, in India, we have a huge population. Our epidemic of pollution increased. With the increasing rise in population, infectious diseases, inflammatory disorders, malignant disorders all went on the rise. We used to die at 50, and that is why somebody was telling me yesterday, this is off the cuff in my opinion, that our forefathers in 1947 put healthcare on the back burner. It was added on to some particular ministry. They never realized what's going to happen in the next 6 to 72 years, that 1 to 1.2 billion people who will not die at 50, they will live to be 80 in the urban areas and maybe 67 in the rural areas. They need organized healthcare. They will have all the problems the Western world has and more. And that is why this is something which did not hit us. Lungs being a common part of everything was very, very important from this point of view. In the United States of America also things have been changing. 1997 I went for a fellowship. I was struggling. It was difficult to get. Cardiology was on the top. Then came gastroenterology. Pulmonary critical care was somewhere lower down. Starting 2017, I talked to my classmate who's a program director. Everyone does well in life. And he says he has 400 applications for 5 slots in one hospital in Texas. So pulmonary critical care and oncology has really bloomed, blossomed and exploded at this point when it comes to the Western world. And then came this magic word, oncology. The oncologists have maximum emotion, maximum support and maximum research going on. If you look at the NEGM papers which come out, every 3rd or 4th NEGM will be replete with oncology with names you can't even pronounce basically. So as oncology increased, they started to do more and more. When they started to do more and more, the end point of a lot of what you do, unfortunately whether it's metastasis, inflammatory problems or infectious problems, hits the lung, a wide surface area. And so oncology and pulmonology started to intricately look at each other. And now I have realized that when I came into the country, 2008, they asked me, can you sample a 8 millimeter lymph node? I said no. And 2012, I walked to and said yes. And 2012 to 2016, we have enough material to put out publications accepted in international journals. So it is indeed an explosion. And that is where we have had a major role to play also. Supply for meeting this massive demand. Sometimes I feel in our field, nobody was looking. There was no overseer, there was no ombudsman. So basically training and exposure was average at best, because the institutions who were going to train did not see this juggernaut coming from the other side of need. And that is why in most parts of India, though we have all the titles, we are very good at our titles. We have 4 types of pulmonology degrees existing, but when it comes to hands-on training, to look at the ability of a practitioner to put all this into place, to gain the highest levels of healthcare, we have a long way to go. So what is the shortfall right now? We don't have comprehensive pulmonology in a big way in most institutions right now, and we don't have coordination. We can't live in silos. You can't say I am a pulmonologist. You are now interacting with everybody out there. Patients are rotating through multiple areas and you can't tell them that, you know what, this is my area only. For them, it's ultimately only one thing. You may do all the rocket science in the world. I want to get better. I want to get out of here. And for that, you need 2 people, 5 people, 10 people. It's entirely the system and the healthcare onuses to try and do that. And so that has been a big issue out there. So lack of comprehensive interdisciplinary care. And on the other side, I can take a whole talk on intensive care similarly. Intensive care was exploding. And most of intensive care, at least 60 to 70% is either whole or in part respiratory medicine. So that is why it became such a big issue. Then comes down to procedure or interventional pulmonology, which is a good deal of what we're going to talk today. It's in the initial but growing stage in this country. And it came down because of the entire background I created over the last 10 minutes, that by and large, the field is moving, the Western world is moving. No longer are we closeted, we are now part of an entire global understanding. We are now looking at more complex patients, we're looking at longevity, and we're looking at the ultimate need for accurate scientific diagnostic and therapeutic medicine to try and take the field ahead. So that, in a nutshell, which I learned myself as I started to prepare this talk, is a changing state of the field, which leads to what has happened now. So what was there from the last century in diagnostic and therapeutic pulmonology? We call it conventional pulmonology. When you basically get a new word, you got to find something to call the old guard. So it's called conventional pulmonology. In the airways, the biggest revolution we had was CT scan. Before CT scan, I think we were at a stage where we can only talk of rudimentary medicine, and that's why you can't blame people for calling us TB, asthma, COPD docs. And then came miniaturization, when the diagnosed fiber optic bronchoscope came, which basically was a reflection of miniaturization in every other area. If you have cardiac cath, if you can have GI, if you can have vascular, then why not in the airways? Airways have a problem, there's air. And air doesn't allow easy visualization, air doesn't allow ultrasound to go through, so it took a longer time to come here. The second problem is pulmonology or interventional pulmonology is the only field where your lifeline, which is the ventilating area, the tracheobronchial tree, and your work area, the tracheobronchial tree, is the same. So it is the only field where the anesthetist who keeps the patient going and the pulmonologist or the invasive pulmonologist who's trying to do a procedure working together. Otherwise, when you see laparoscopy, there's a procedure going on in the anesthetist at the head end, and that's why you see many jokes about how they're relaxing and so on. So they have their own area, the other guy has his own area. Here it's a shared area. So all this is the reason why this field took a long time, and that is why everywhere it was surgery, surgery and surgery, because that was the easiest. And initially everything the surgeons have picked up more, then we have come down. So your landline has given way to your current fancy iPhone 10. So similarly we've seen this transition going. So in the airways it was these modalities. In the mediastinum we should look at CTs and then figure out what's going on, otherwise straight it was surgical. In the pleura, again CT chest, closed pleural biopsy, which has been around for a long time, again surgery after that. In the parenchyma, the same bronchoscope allowed you to do a transbronchial biopsy, but otherwise it was surgery only. So what has led to advances? Well, I talked of this and I am reiterating that as a checklist. One is technology. Secondly, re-emergence, marketing. I use that word not as a word which is used in conventional sense, marketing, because people who were talking and doing in their own areas, in their silos, started to talk in the rest of the world. So Europe, who pretty much believes in publishing only in Europe, Germans in German literature, the French guys like their literature a lot, and they did a lot of the work. They ultimately came around. So as people moved around, they started to put this out there. So that is why it became global. And then the single word internet, which has impacted so many aspects of our existence, both positively and not positively, led to an explosion of this sort of understanding. First of all, know that such a thing exists, then try to see if it's applicable to you, then try to get the science to your own setup, and then try to see if it works for your patients. E-learning became a part of that, and as we reiterated and as your dean rightly said, need for more accurate diagnosis, because the organized mind is very clear. The organized mind will not jump onto treatment without diagnosis unless it's a dire emergency. The only time we jump in is when it's a dire emergency or your neighbor is hounding you. Otherwise, you never do it. You will try to make a diagnosis. Your diagnosis will decide everything. Next level of testing, what is your management plan, what is the complications you expect, what is the prognosis you plan to outline, all of it. Not to mention the fact that in your heart, being a doctor who wants to take the science ahead, you're educating yourself at the same time and trying to, if possible, educate others, as in this forum, or putting out in peer-reviewed literature. So that was very important. And then what I thought was very fascinating, and the seniors will, in the audience will agree with me, offering therapies where we gave up before. And it has been a conditional change of mindset. We allowed people to die in the 80s and 90s. When I trained, all the C's were really bad. COPD, CHF, CRF, CVA, cirrhosis, they all died. And in fact, we would never take them into intensive care units. And we had a very busy one in Mumbai, 20 beds. I would call up and say, I want to shift a bad COPD. He would say, no bed, and slam the phone down. No questions asked, basically. And I would be fielding for myself for the whole day and night trying to figure out what to do. So they all died. But now, it's not that way anymore. We are offering therapies where we gave up before, thanks to this whole thing. And I always like to put this, pulmonology is catching up. No longer those two massive lungs sandwiching a small heart, a poor cousin of that small heart, because indeed, the diseases were there, the problems were there. It was just that we did not recognize it. And certainly we can do more, which is the impetus of such talks. We shed the TB and asthma doctor label, and we did much more, which is what we're going to talk about today. So what is this field, and I made such a big case for it? What is interventional pulmonology? Well, the playing field doesn't change, and I'll get the playing field here for you. We have very simple, there's nothing complex in the lungs over there. There is airways. Okay, you can make out over there. It's like any highway. I came on a highway, it bifurcates, ultimately reaches your house. There is parenchyma. There is the part around the airways we don't see, that is called mediastinum. And the lining of the lung is called pleura. And chest wall and all, we're not going into at great length, but this is what defines the playing field. So this is what we do. When you put a scope inside the airways, it's called bronchoscopy. When we look into the pleura, it's called pleuroscopy or thoracoscopy. And when you look into the mediastinum, it's called mediastinoscopy. That's all it is. So there's no huge thing to all that stuff. So that is what the field did, that bronchoscopy and pleural procedures taken to a new level. And that's where we realized internally, confession, we as physicians moved out of our comfort zone. And those of us who had a little surgical DNA are willing to get into that, started to look at that a little more. Again, any arena of medicine has both diagnostic and therapeutic procedures, airway and pleura over here. And I made enough of a case of oncology, and especially when lung cancer exploded, smoking, pollution, a myriad of reasons. And in India, we're going through our own epidemic right now. We have so many solutions coming. We have so many. In the last 3 to 5 years, we have seen 3-4 generations of a drug called tyrosine kinase inhibitor. Now, all of them are marketed out here. But we never learned how to diagnose these. For to use this drug, we need tissue. We need the tissue to prove it. You cannot put somebody on, first of all, a drug which may have side effects, which is empiric, and which may cost 1 lakh a month, even if they can afford it, or the system is going to afford it, if you haven't proved anything. So lung cancer and the need to, the therapeutics part. So it's very, in one way, interesting, but also tragic, that the therapy guided the need for more diagnostics, when it should be the other way around, that you're diagnosing a lot of stuff, and then you're planning how to do your therapy. It's like basically trying to first declare the college and then put the building, rather than get the building ready, get everything ready, and then the college opens. So it's become a challenging field at the cutting edge of modern pulmonology, and we'll talk about all that. So we told you about this, and we'll now, in the interest of time today, I'll not be covering anything but airways and mediastinum, and that too I won't go through everything. The idea is to give you an overview, perspective, a preview, and then we can take it from there on how to educate further. So today we'll be concentrating a lot on airways, mediastinum and parenchyma, and depending on the amount of time we have, we'll try and see how much we can cover. So topics at the cutting edge, which is the case I made: diagnostic bronchology or working in the airways, conventional bronchoscopy, the term I used, endobronchial ultrasound. And so again, fancy terminology and acronyms should not confuse us. Endobronchial ultrasound basically means that we can put, just like the GI guys, you've heard of ultrasound. Ultrasound is the most common application on the surface. When it starts to get into body cavities, it's called endo-ultrasound. So you have vaginal ultrasound, you have GI ultrasounds, you have cardiology ultrasounds, all of them are there. And now we were able to put the same ultrasound probe in the bronchus. It's called endobronchial ultrasound. Then came another science called cryobiopsy. I'll talk about all that. So this became very fascinating, that all what was dark started to light up. All what was inapparent and undiagnosed started to make sense, basically. And then when we started to do this, we started to get into the therapeutic arena. And therapeutic bronchoscopy can be epitomized by this difficult case. Somebody whose highway of life, the trachea, is basically blocked by this tumor, stridorous, dying. Can we do something other than what we used to do before? And in the midst of all this, as the field progresses, when you started to run into difficulties and you didn't know what to do, but the patient could not give you time, and time was life, not money, for God's sake. We don't talk of money a lot in medicine all the time. It came down to innovation. And that is where the field progressed even more, where innovation basically had a role to play when it comes to all this. For those of you who still can't smile, kindly focus over here. Okay, fine. So what is there in 2018 at this point? To get some of the didactics done. Tools in the diagnostic bronchoscopy spectrum: transbronchial needle aspiration will touch on that, endobronchial ultrasound will touch on that, radial EBUS will touch on that, cryotherapy will touch on that, and then we'll go into the world of therapeutic bronchoscopy in the time we have. And then the whole thing will be demonstrated by cases which will make a lot of sense. And what is done, keep in mind, we're not talking exotic stuff pulled out of YouTube. All these cases are done very much in India, in our own setup for our own patients, and has made a remarkable difference in their care and very confessionally our own understanding. I now feel, and I'll confess to the young people here, I did a whole American board, pulmonology, critical care, internal medicine, and everything. And what I've seen in the last 10 years in our country and what has been unleashed over here pretty much reflects something which we never trained in, because it was not there at that time. When I left America, 3 fellowships only, very difficult to get in, an arm and a leg. Now there's 30 fellowships out there. And you can imagine with 300 million people, if they're talking of X workload, what is the sort of workload we have out here. So, mediastinum, let's talk of the mediastinum. We talked of the fact we're going to touch on those 3-4 areas. Diagnostic bronchoscopy typically is put a scope in the airway. Look in what you can look. I enter this room, I can see this room out here. I can see a few people sitting, I can see chairs, I can admire the walls. So that is how we are taught. Look at the mucosa, look at the carina, look here, look there, and everything. But what if there's a sound coming from outside there? And what if can I do something about that? In the initial arena, that was all surgical stuff going from there. Or the CT scan may give you an idea. But now, if I can go from here and sample that area, I can probably make a diagnosis. And that was the whole idea, that through the bronchial tree, you can put needles or outside into the mediastinum and give enough tissue to try and make a diagnosis in common entities like tuberculosis and cancer. And understand that this country is a country of mediastinal lymph nodes and pleural effusions. We are replete with it. We are full of these things, and so far it's been treated empirically as much as possible by clinical judgment. So here what we do is that we use CT scan with clinical judgment, and then we get the pathologist to the bedside. They also get better and better, that they're going to look at the smears, do a cytological analysis, enhance their old capabilities and skills, and give us an answer. Then we took it to the next level, which I'll talk about in endobronchial ultrasound. So to put this in simpler perspective, this is the bronchial tree. The lymph node sits beyond the bronchial tree. So we're showing you this green stuff here to show you what you cannot see. Like I said, it's beyond that wall out there. And in the early 70s, a gentleman called Copen Wang from Johns Hopkins in the USA said, what if I can put a needle based on the CT scan and my best estimation get an answer? So this was transbronchial needle aspiration. Typical cases like shown in this X-ray, this person has a mediastinal lymph node over here with clinical symptomatology. Common differentials are TB, sarcoid, or lymphoma. What is going to be there out there? Such needles were made then, which can go, tiny things going through bronchoscopes, which can look at this node and sample it. So this is the bronchial wall, needle piercing through the bronchial wall. And in this video, you'll know exactly what's going on. So you can see we're in the main trachea, right and left bronchus. This is the lymph node area. I talked of it being beyond. This is the needle invented in the 70s, which took a very long time to reach us. And the science did not pick up for ages. I think it's a freeze of medicine at that time. And that is why I came to you with that word renaissance. And you can see how the needle is put over there through the wall. People construed this as dangerous. It's actually very safe and done outpatient. The needle is there, and then a syringe is connected outside to aspirate from the lymph node. This is transbronchial needle aspiration of a mediastinal lymph node by good clinical judgment using a CT scan and a good bronchoscopy operator to try and make a diagnosis. So you can see how then we agitate over there because the needle is trying to move stuff inside the node. You can't see any of this stuff, but this is what happened for 20 years as the science of conventional transbronchial needle aspiration. The needle is taken back in the airway and then it is removed and cytological processing is done. So this went on for many years, and in India this did not pick up a lot. In fact, it was very difficult to the point that Dr. Mehta and his colleagues had to use a lot of clinical medicine because we did not get tissue. Can we do this easily? Of course. Look at this case over here. 65-year-old smoker, past history of TB, gets hoarse, treated in Mumbai by ENT. Pulmonologists both say, okay, he said you've got TB again because it's most likely your hoarseness is your recurrent laryngeal or AP window involvement. No response. The CT scan was done. CT scan showed a node mass-like area in the left, so it's not too difficult. This is the left paratracheal. Trachea, right main bronchus. So left paratracheal shows this over here. Well, we sampled the same thing using, you can see the needle going into the left paratracheal area, also sampling the subcarinal area, and this came back as large cell carcinoma. It wasn't a tuberculosis at all. But anyway, the slide was showing features of large cell carcinoma. We have the actual tissue. Why we show the tissue is very clear. you will actually believe that cells can come from this procedure, and this procedure can be used to make a diagnosis. Then the science went ahead. For 25 years, from 72 to around the end of the century, we were doing this by clinical method and called it conventional transbronchial needle aspiration. Meanwhile, as I said, cardiology, gastroenterology, even gynecology, everybody was putting the ultrasound into several orifices. So it took a long time to build this prototype, but the prototype came that if we can put an ultrasound on the tip of a bronchoscope, then we can actually see this lymph gland, and sample it, and that is endobronchial ultrasound guided transbronchial needle aspiration. So the same node can be sampled. This schematic shows you the scope which came out. This shows you how it is there in the scope. This shows you the needle which samples, and this shows you the lymph node. And the lymph node is very similar to what you see when you do a regular ultrasound. So this is the schematic. This is the main trachea. You can see how the scope comes here. The lymph node is here, and the lymph node is sampled using the needle. This is endobronchial ultrasound. This has become standard of care. In 2002, it started, I think, in America. America has 600 to 800 of these. In 2008, it started in India. We started with one in Coimbatore. We got the sixth one in the country, and now there's at least 130 of these in the country, used by people to try and sample lymph nodes. What is the case to try and elucidate this particular concept? 41-year-old with fever, dry cough was given antibiotics, as often happens. The scan showed prominent hilar nodes, and each one of you will have to look at X-rays. So these are the things you appreciate. CT scan shows large lymph nodes out here. The arrows are showing all that. Endobronchial ultrasound was done, and you can see how beautifully 1, 2, 3, 4, 5, and you can see vessels inside. So one look and everything opens up in front of you. The whole cosmos of the mediastinum opened up in front of us when we started to do this particular procedure, and this video will show you how it is done. So again, patients under conscious sedation, little metazolam and fentanyl. We can see vasculature with a Doppler. You can see lymph node. You can see how nice. This is a capsule of the lymph node. This is the superior vena cava. This is the needle entering. So what we did with clinical judgment in what I showed you was conventional TBNA. Now is done by visualization. It can be marked. It can be documented. A report is given which can be objectively seen. We can appreciate lymph nodes, vessels, everything. We can get more and more material. And as we started to do the procedure, oncology got up and said, I am here. Give me this much material because I'm coming out with 4 markers in the next 5 years. These markers will help a 40-year-old who has advanced cancer to live longer. So get me that tissue by as accurate a method as you can. So all these have really helped and revolutionized, if I can use that word, in trying to regimen the care of these patients. And here you can see again multiple lymph glands everywhere in the tracheobronchial tree. We could navigate as long as they're close to the tracheobronchial tree. So that was the whole science of endobronchial ultrasound. In this patient, we got granulomatous inflammation, proved objectively. The workup for granulomatous inflammation involves ruling out TB, making sure there's no lymphoma, obviously, and if everything is negative in the right clinical picture, this is sarcoidosis. This is objectively proven sarcoidosis. In the years we trained in Mumbai, we were told there's no sarcoidosis in India. I still hold on to a textbook which tells me that. By the time we've done all these procedures in our own series of 600 which we've published, we have 30 to 35% sarcoidosis, and it's well acknowledged now that it's quite common in our country. It's not as rare as we thought it used to be. So you guys in your science will see a lot of this. What we say, and we say with supreme confidence in medicine, ultimately we have to review, look at, eat some humble pie, and a lot of people from the external world are auditing us and saying, you guys do stuff which you forget and you don't do the right thing. And keep in mind, whenever you do something, put it in the right context so as to facilitate patient care and just not be there because you think it's correct. So a lot of these things have moved over time in a very comprehensive way. And the same thing in pulmonology. Now, I showed you parenchyma of the lung, 2 large lungs, 6 million alveoli. Can the same ultrasound be taken to the parenchyma? Well, it can be. And you can see what they did is that they got a small probe, and the probe goes through this bronchoscope, and the probe has an ultrasound at the tip. And this is the way it works. You can see that this is a tracheobronchial tree in this schematic, and here is a lesion sitting close to the airway, but in the parenchyma. This is the ultrasound probe which comes, and this is now, you can see that on a monitor, and in the right situation when it reaches there, it's going to show you the ultrasound image. So now you know, just like you would use a GPS and you use Google Maps to reach anywhere, you can use some of these things to try in the right patient to reach there, localize it where we used to use a lot of clinical or couldn't do it before, only had surgery, and try and take biopsies. So this was the whole science of what's called radial EBUS, and this really revolutionized the sampling of parenchymal lymph nodes. To show you a particular case on this, a 66-year-old with dry cough, a mass, CT scan was done over there. You can see it's in what's called no man's land. It's not easy to sample from here. It's not easy to sample from here. You'll get a pneumothorax. So at this point, we also have a lymph node. So multimodality kicks in. In this patient, we want to sample this as well as sample this. And the whole science of oncology went on to saying we need stage. Staging is done as a systematic part of all oncological workup. And so to stage these patients, the more you can sample, the better, especially when it comes to the lung. We went and did that same EBUS of that lymph node as we talked about, and then also went ahead and sampled that mass, and I'll show you this video out here. This video shows us what we could see over there. The lung is like a wonderful snowstorm. You won't see one in Hyderabad, I'm sure, but a snowstorm appearance because it's all air. And then suddenly we start seeing a different appearance. And that for us is lesion. So it's not a very steep learning curve. It's actually a pretty shallow learning curve. And we can see the operators moving to and fro, just like I showed you in that video, to try and localize and get the best image he can of this area. And this is a wonderful image. This shows that this is the lesion, this is the capsule, and this is the lung. Once we are there, we can go ahead and biopsy this lesion. This was the science of ultrasound going to the parenchyma, also called radial EBUS. This came back as adenocarcinoma of the lung. Things got more fancy. Now then came cryotherapy. Cryotherapy is cold energy used in the eye most commonly when they try to take out cataracts. Turns out you can make a probe, send it to the bronchus, and if it freezes at minus 89, you can't even imagine. If you put it on your finger, it will take your finger off. But when it freezes at minus 89, that tissue can be taken out. The good part about freezing, when you do it for biopsy, you do not distort architecture. And that is what pathologists love. So cryotherapy came as a cold entity which can stick to areas and take it out. And now the inquisitive mind had to figure out, how do I use cryotherapy? How do I use it in the airway? Well, many applications came basically. A main thing was that if there's something stuck out here, I will show you tumors. You can either take out tumors, you can take out foreign bodies. It's not easy to take out a peanut. And the children of India tend to put peanuts into the airways left, right, and center. Even adults, you should see the number of foreign bodies we all have to deal with, and I'll show you one very interesting one. In such a situation, to pull them out is very challenging. It has been the purview of an ENT person, occasionally thoracic. It's very sad to put them through surgery. If you have to do cut surgery for foreign bodies, it's very sad. People can also die. You can get collapse, you get infections, and so on. So that was one application. Then came tumors, that if there's a tumor sitting there, why not grab it, as I showed you initially. And then we realized that there's more stuff you can do in the parenchyma. I showed you radial EBUS for parenchyma. What if you can take a parenchymal biopsy? But then which condition would require a parenchymal biopsy of a large nature? And then something called ILD came. I think some of you guys must be familiar with interstitial lung disease, which is thickening of the lung. Lung, a lovely, spongy, open organ, becomes stiff, scarred because the interstitium, the walls of the alveoli get thickened. For interstitial lung disease diagnosis, cryobiopsy has become a revolutionary thing in the last 3 years. To our own amazement, how it has made a big difference in diagnosis. And I'll show you a picture. So you can see what is happening out here. This schematic explains everything. Lung, interstitial lung disease here, bronchoscope, cryoprobe going there, freeze out there, and you can get a sample. And this video will show you exactly what we do. CT scan showing this white stuff is the bad interstitial lung disease. And you can see how we put a cryoprobe. Ignore the balloon for now. It's one of the technical things we do. You can see under C-arm fluoroscopy, the cryoprobe is coming. We keep it in the area of abnormality, freeze out there and pull. And the balloon is used to prevent bleeding. You can see how this will take the whole tissue out from there. And that tissue is then thawed. And when you take 4 to 5 pieces, you achieve 80% that of a surgical biopsy, which was never seen before. 30 years, nothing has moved in diagnostic. Such large pieces are obtained. This is a post-op X-ray, and this has been used to make a diagnosis. The science has progressed to a point that now, in 2018, it is now accepted in many parts. Again, Europe ahead of America, and India working its way ahead with other parts of the world. So this is the cryotherapy paradigm. What case to show you foreign body cryotherapy? Somebody took, ingested a foreign body a week ago. This guy likes to eat supari, and he takes large pieces and puts them and he keeps them there. You must be used to those guys. I mean, half of your population in certain areas does that, I'm sure. And so then it slipped inside when he coughed, and then they tried to take it out. They did around 2 bronchoscopies, 1 rigid bronchoscopy, fairly decent people couldn't take it out and left it out there. So now the problem is lung is completely collapsed out here. Do we have to put him through surgery or is something more possible? And this fascinating video will show you everything over there. So you can see here the collapse is showing up over there. And we go inside, we showed you the trachea before, and this is all. The right main bronchus, what's called the bronchus intermedius, shows pus, shows a foreign body. It can't come out by other method, so we put this cryoprobe. See, minus 89 degrees freezing. It holds on to that, and we start to pull it out. This is a rigid bronchoscope barrel through which we have used it. And you can see more suparis coming up, and it didn't end, it went on and on and on. It took 30 minutes, and you can see one piece. We thought that was the end. We went in, one more fellow was coming up over there. Again, the same thing utilized out there. Then we saw pus, post-obstructive pus, which tends to be the worst part of the whole thing in addition to lung collapse. Hunted again in that pus, more of it came, and you can see massive 2.5 to 3 centimeter long, large supari was stuck in there. Very difficult to hold this with forceps and pull out. It was not possible earlier. We go in, and lo and behold, all the distal airways are recanalized, they're inflamed, but that settles. Human body is wonderful in trying to reduce. So this is what was there, the beetle nut, which ultimately was removed by this wonderful cryotherapy. Same thing for cryobiopsy. We have this 56-year-old lady whose CT scan showed bad interstitial lung disease, also lymph nodes. So now we are starting to practice multiple things. We'll be taking the EBUS and putting it in the lymph node if we suspect it, if we think it's required. We'll be taking the cryoprobe and putting it out there. And so we went ahead and did that. Again, another schematic to show you the same thing, how this cryobiopsy was done. The scope goes in, cryoprobe goes in, samples are taken. And we have shown you this before, but this is again done over here, and it is done in a safe way, as by and large a one-day procedure as against cut surgery, and of course drops the cost also, which is so important in modern healthcare. We got large pieces. You can see the size. We're talking 8 to 9, 10 millimeters long basically, and this is a sort of histopathology. We never used to see that before. So I know you guys are young. For you guys there is no comparison, but understand that when I come here and talk to you, I'm talking to you with that sort of amazement that if you don't see something in 8.5 years of your MD, and then you don't see it for 9 years in American training, but then it comes to you and it redefines a disease. It redefines how to approach the disease. It is when that modality hits state of the art, and that is when we have to integrate that in what we do, at least know about it or send it to the right person who can do it. So this came back as an entity called NSIP. It's a whole science by itself, but that is diagnosis. It helps you to pin down the diagnosis, which ultimately makes a difference in the management. So this was diagnostic pulmonology, a lot. I'll try and walk you through therapeutic pulmonology. I may skip one or two things if time is short. There, by and large, I showed you airway. It's airway stenosis and obstruction. I'm not getting into pleural stuff out here. And things got more and more fancy. When it leaks, it's called bronchopleural fistula. When you cough out immense amounts of blood, it's massive hemoptysis. When you try to do something more for diseases like asthma and COPD, we entered arenas of what's called thermoplasty and lung volume reduction. Many terms, many confusions. Just try to understand basic concepts of how the field has advanced. So this schematic will not require many words basically. Airway blocked, scarred, narrowed, pushed, whatever it may be. So by and large, this narrow tube called trachea, 2 to 2.5 centimeters, are lifeline, made by the good Lord as being cartilaginous in front and stiff and floppy behind. If it gets narrowed, buckled, pushed, compressed, we are in trouble. These people die. They can't breathe. So first goes quality of life, then goes existence, and ultimately its demise, and it can happen at any age depending on what causes it. Most common in India is post-intubation. We're doing a lot of ventilation. I spoke of ICU increasing a lot, post-tracheostomy, TB, which is still there in our country in a massive way, and foreign bodies, and cancer. So these are the common things out of this whole list which does it. What could we do to open it? Ultimately, the same principles in other parts of medicine applied to the endobronchial tree. What do you do in surgery? Hot energy, cautery; cold energy, cryotherapy, which is used in the eye; mechanical energy, use forceps and instruments and so on; stitches, that's what you do. So that's what the same thing which came to the endobronchial, the bronchial tree, the trachea and the bronchial tree. Thermal energy is hot energy, laser, very common in the Western world and Europe. Hardly it has because they're very expensive. But we got the cautery. We basically in our science have been masterful demanders. Demanders is a polite word for begging. Basically, we've gone through everybody's suite and begged. So the surgeons have a cautery, we took it from them. Gastroenterologists got a cautery, we took it from them. We got our own conduits because we need large conduits to go through our scopes. And then we had to figure out how to keep the person alive at the same time as doing work in that same territory. It's very difficult basically. And that is why it took time, but it got there. And these are the tenets of whatever tools we use. So this is hot energy, cold energy I showed you over there, and mechanical debulking was the rigid scope which I showed you a preview, and more things which are there. You don't need to go into each one of these details at this point. The cardiologists invented angioplasty. Basically, it came from other areas, but it picked up with cardiology. It went to GI, went to vascular, finally came to us. We call it bronchoplasty. Basically, it's a balloon which goes in the bronchial tree and opens it up. And just like there are stents in other areas, in the right situation here, you can see this tumor is pressing on this tree. You have to put a stent, and these are the stent generations. So many of them, right? But till the last 8 years, none of them came to India. Nothing came over here. Whether it was our whatever reasons, not worth getting into in a talk like this, but none of us. Now the last 8-9 years, we have a lot of armamentarium out here. We can use a lot, and we've been able to use that to basically take the science ahead and help our patients a lot. To the point that from 2008, when we started doing all of these things, a few of us in the country also networked, to 2018, we ever had people coming and telling us, our UK colleagues and the US colleagues told us, before we used to come and teach, now we come for exchange of ideas. So that has been one of the biggest transitions in the last 10 years we have seen when it comes to this. Case to show you all this stuff, a 57-year-old comes with dyspnea and stridor, and you can understand why. Main trachea blocked, horribly blocked. It should be a big open hole. 80-90% blocked. No wonder the gentleman cannot breathe and he's going to die. And this one look says everything. Trachea is blocked badly. If you cannot ventilate, he is not going to make it. We went ahead and used all those things. The rigid bronchoscope goes as a conduit. That is your conduit. Through that, instruments will go in. Hot therapy, cold therapy, whatever, balloon stents. So this is the tiny area you work in. That is why this is more challenging. And this video will show you everything. You can see how the tumor is blocking out there. It's quite precariously placed and life-threatening. These are the various CT scans which give you an idea. Bronchoscopy showing the same image I showed you. And now the therapeutic tools kick into action. So that was rigid bronchoscope barrel. This is a snare. Understand the miniaturization, and that is what I'm here to show you today. All miniaturization, these tiny, tiny things. Now we're going to put hot energy through this snare. And this is going to burn the whole thing. Side by side, we are ventilating. We have 2 to 3 minutes, otherwise you will have hypoxemia. The mask goes below, we recover it with cryotherapy. We showed you that. See how the cryo is used to quickly pull it out. So combination is being used out there. And the process continues until, and then we finally burn it with another hot modality, another cautery out there. With recanalization established, the patient can breathe, the job is done, you have tissue to make a diagnosis, you have given time, and further management can be planned. And you can see the bronchoscope going again nicely showing the cauterized edge of the massive tumor with open bibronchial tumor trees and the large tumor which came out. So this was a particular entity called adenoid cystic carcinoma. We told you about we ventilate a lot. A 13-year-old young person, decay, is a juvenile diabetic, gets ventilated 2 to 3 days. Ventilation practices vary in our country, develops tracheal stenosis. This is supposed to be in a 13-year-old at least 12 to 15 millimeters, and he cannot breathe. Bad stridor. So they usually come out of one crisis and go into another crisis. And here you can see what's going on. We go in with the urgent bronchoscope. It's a mess out there. It's a web. Basically, it's like this door you just can't enter. Not even one human being can enter. We don't have time. Patient's desaturating. A quick balloon goes. We talked of balloon bronchoplasty. So this balloon goes, opens up the airway. The anesthetist is getting stressed out with us. I need to ventilate. Give me that airway back. We do that. Then we have to consolidate our results. We put a stent. I showed you the stent generations. This is a silicone stent which was put in the airway, available in India, can be done for our patients in 10 to 15 minutes. And that is what the time you have. You don't have more time, at least for opening the airway. Patient gets recanalized, outcome is good, and then you have to manage the rest of it later. Similarly, another case, a farmer comes to us, can't breathe, short of money also, difficult. His right main stem shows this massive tumor out here. First people thought it's cancer. It's not cancer, it's benign. It's a leiomyoma, not a common tumor. The plan was thoracotomy, cut the chest, cut everything, do that. Complex surgery needs very skilled people, expensive, morbidity, mortality. They said, can you do stuff endoscopically? We said, sure. This was in the early years when we started, a decade ago. We use hot therapy again. We start to cauterize it. We use the same snare. In the interest of time, I'll show you what happened in the end. A lot of it is taken out. The right airway is recanalized. Now you can see how the whole thing is gone. We make sure we do a good job, and this guy never leaves us. These patients become actually literally part of your family. Anything in the lung, they will come rushing to you. He comes from Mandya, which is quite far for us. Anytime, I keep telling him, you don't need a bronchoscopy, but he came. Initially, we wanted to do it at 1 to 2 years for surveillance. Clean airway. No cut, no surgery, day 3 discharge, day 5 back to whatever he wants to do. And recently, just on his own insistence, because he was very worried, those guys remember every part of their trauma, and so will we. At 6 years, we still have the same outcome in this patient. Am I saying everybody will have this? No. What am I saying? I'm saying that these are options never before available, which can be done in our country. And as I confessed to you, we also did not see them in all the Western training because it wasn't there at that time. 45-year-old, bronchial asthma, CA esophagus, poor young gentleman, has dry cough. People think it's asthma exacerbation, comes to an emergency room, given nebulizers, given steroids. X-ray shows some little, we're not happy with this opacity, but the CT scan shows that there is tumor out here. The esophagus tumor has come into the airway, so this is not asthma exacerbation. This is CA esophagus with tracheal infiltration. It's becoming an emergency. He's desaturating. He cannot breathe. We go in there. You can see how the whole thing has pushed up. So it was incorrectly thought of being an asthma exacerbation. They call asthma mimics. We then have to define the distal airway. We use tiny scopes. So this is a change of scope. Technology, ladies and gentlemen. Again, a large scope replaced by a small scope. You can see beyond it. We've gone ahead. And this is all pus collecting out there. So it is a young fellow with CA esophagus, obstructing trachea, post-obstructing pus, will lead to a pneumonia and a life-threatening crisis. Y stents are used for this. So I showed you the trachea and 2 bronchi. It's a Y shape, inverted. So Y stents available all over India. In fact, we have metal Ys more in India than in America. The US FDA has not given approval. So this gentleman required a Y stent. You can see the left limb, the right limb, and coming up the tracheal limb, which basically completed the job in terms of recanalizing his airway, and at least life can go on and multimodality treatment can be applied. So he was discharged, and the advantage is instantaneous reversal, because you don't have to, there's no cut, nothing. It's all here. They get throat pain for a day, and next day they're much better. So all of these can make a dramatic difference. And I like this case to show you what dramatic difference can be. A 23-year-old tailor, stitching. And when they're stitching, basically they put needles into their mouth. So he put his needle and he was continuing to do his job. Both hands busy, foot busy over there. Somehow coughs or takes a breath, needle gone. And so they hunt for it and say, where is it? And it was hopefully it will show up. Yeah. So you can see the needle is here. One X-ray shows the needle, and everyone expects. We love it to be in the esophagus. At least it's easier to take out. Not in the esophagus, it's in the windpipe. And typical of a needle, it's like Lancelot's sword. It's going to go all the way down to the most distal airway. So you can't see it for nuts, to use a crude word. And so you can see how this needle was sitting here. It's so difficult. It's close to the diaphragm, and you can see this hybrid video will show you what was done for this. So you can see here, this is under fluoro. We can't, so it's a big challenge out here. I will pause for a second if I can to tell you what the challenge out here. 2 millimeter airways, no vision, 3 millimeter scope, and all you're seeing in the C-arm, and you're trying to go there and hold it. If you turn too much to one side, you'll perforate. If you don't do the right angle, it's not going to come out. So it's a big struggle out there. So it's a combination of hand-eye coordination, C-arm working, and good assistance for opening the forceps. The idea is what? Take it from there, bring it to the main airway, bring it to the highway. In the highway, you can deal with it. But if the terrorist is sitting in his little hut over there, you can't take it out. So similar thing happened out here. Now I'll let the video speak for itself. You can see how the operator is struggling out there, trying to make it straight and get it up to the main airway. And that is where there's 5 voices. I've shut the voices. You've seen the tension in the room at that time. Move here, move there, everything was going on. Again, we're trying to follow the tracheobronchial tree and come to the main airway. Did we succeed? Yes. So once it comes to the main airway, the rigid bronchoscope with the appropriate tool or forceps is used. It is taken into the scope. Otherwise, it can damage the tracheobronchial tree and even the vocal cord on the way out. And ultimately, this 3.5 centimeter long needle was taken out of this tailor. The only joke was that unfortunately the needle costs around 20 rupees. Procedure cost was around 500 times more than that. But that was the whole thing. Now, in terms of more stuff, I think what we'll do is I'll skip this part of it and try and get you to the later part of the talk. Bronchial thermoplasty. Asthma has been a medical disease all this while. We give inhalers, more inhalers, and there was a whole GINA guideline which is there for the last 25 years trying to streamline the care of asthma. In the last 2 years, a new entity came. Refractory asthmatic, bad asthmatics, and I'm actually taking a talk in the city of Hyderabad, which is known for its fish therapy. My colleagues till 5 years ago in asthma talks used to trying to put fishes out of the airway when people aspirated them. But now it came down to the fact that refractory asthmatics, where nothing is working, who are getting exacerbations day after day, the child who makes it to the newspaper, basically that brittle asthma, those who don't get time to reach a hospital, those whose life, quality of life, family life is completely deranged because of asthma, can something more be done? And the big science came that if there's a smooth muscle hypertrophy in asthma, if you can reduce the smooth muscle and make it a little more inert by using radiofrequency ablation. I use this paradigm with you, ladies and gentlemen. We have borrowed from everywhere. Radiofrequency ablation has been used in gynecology, used in radiology, used in cancer, everywhere. So if this same radiofrequency ablation can be used for smooth muscle reduction of mass, then asthmatics can have less exacerbations, better quality of life, and this procedure is called bronchial thermoplasty. Hit India in the last year and a half. Still, of course, reserved to only the severe asthmatics. This schematic shows you what it's all about. This is your airway and mine, assuming we're not asthmatic. This is what happens when we age. It becomes a little thicker. But asthma people get this extreme thickening of the airway, of the smooth muscle, and narrowing of the airway. Note both of these features. Thickening of the smooth muscle, narrowing of airway, which if you can address, you can make their life much better. And this procedure shows, this video shows you what thermoplasty is all about. So in bronchial thermoplasty, you can see the airway out here, main trachea, right and left main bronchus. You're trying to address the bronchi. This is nothing to do with the parenchyma. And this schematic shows you how this is the smooth muscle out here. And how this gets thickened. It's called excessive smooth muscle in the poorly controlled asthmatic when everything else has failed. You can see how it narrows the lumen. And how in a severe asthma attack your lumen comes down to bare minimal, which is the reason they are critical, they are sick, they are worried, and which can be life-threatening, requiring healthcare again and again. This is how thermoplasty is done. The bronchoscope is put down. Everything works with the bronchoscope. You know that. I've showed you enough and more today. It goes over there. It is now trying to address these airways. The smooth muscle is thick over here. The lumen is narrowed. This is the radiofrequency probe. Approximation happens. The 4 edges here are now equipped to give that radiofrequency energy. It's heat energy ultimately. I told you everything is heat, cold, or mechanical in medicine. This heat energy is given out there. The heat energy works on the smooth muscle, doesn't affect the mucosa. The smooth muscle shrinks out there, which gives you more lumen back and also affects the basic physiology of asthma, which is smooth muscle contraction. And that is how these patients get relief when nothing else has worked. So this is bronchial thermoplasty, and this is done in both lower lobes and in the upper lobe because you have to cover quite a bit of airway before you can make a tangible impact in your patient's care. So this has just come to India and again represents cutting edge where there was no procedure before in asthma. We have a procedure to try and make a difference, but only in the right subset, not in everybody. So we talked through a lot today. We've basically gone through what pulmonology was. We made a large case for over 4 decades how things hardly moved to did not move. And then we made a case for what is happening. I told you about the differences in India, America, the huge requirement for this, and the work which is being done out here to make a big difference in both healthcare, science, and in the care of our patients. It comes down to what Dr. Mehta will identify with very strongly. Are we contributing to the field and world literature, or are we just espousing our cases? Are we a factory of only service, or are we also adding to both research, development, and putting our imprint in the world by and large? Yes, we are. And the reason we were able to do it is because it was virgin territory. It was unexplored. The patients were waiting. The technology had to be applied. When it was applied, we managed to do a lot of stuff. I'm putting some of our work out here, though of course in the country we've got 3-4 centers, PGI, AIIMS and enough who've done all these things now. We managed to invent and publish the first indigenous blocker in world literature for bronchopleural fistula. We got the stent which I showed you can migrate. We put a stitch and we got the first stent stitch accepted in world literature. The conventional TBNA I showed you, we got 600 cases and it redefined the spectrum in India. One of the first few papers to ever put the spectrum in India into our knowledge. At the same time, the largest, the third largest, one of the 3 largest in the world literature when it comes to this. We use the endobronchial ultrasound to sample areas, transpulmonary nodes never described before to get tissue diagnosis, and so on and so forth. So bottom line is, I'm not going to inundate you with complex stuff. That is a specialty area. I want to leave you with one message, that when you have the right application of the right mindset, judiciously applying the right technology in a responsible way for a science which mandates it for both diagnostic and therapeutic arenas, you will make a difference. And if you can publish it, it becomes an imprint in world literature. And these are paper on paper which has come in the last 2 to 3 years. This is our TBNA paper, this is our blocker paper, this is our stitch paper, and to make it interesting, we like to make things interesting. We call it the hitch stitch. Then we have endobronchial ultrasound paper, and so on and so forth. So there are many like these, and we didn't stop there. We realized that the whole world is looking at multi-center. So 6-7 of us all over the country, PGI, AIIMS, us in Apollo, a colleague in Coimbatore, one colleague in Delhi out of AIIMS got together, and this is just a small series of the 7 papers which have come out, where everywhere we've taken multi-center data, put it together, and showed that we can do it, to the point that some of these things have never been described before in the world literature, have been accepted very well. So what does it take to do this? Is it simple? Is it just sit in a room, talk, and have a nice invigorating session? No. It's a multi-specialty model. It takes a lot of effort. It takes, of course, pulmonology, as we talked about, in collaboration with thoracic surgery as needed. But as we go more and more, their contributions getting less and less for hands-on. So a lot of our colleagues will say, where's thoracic standby? Which is the last bypass, which is the last angioplasty which ever went for a bypass. In angioplasty, we started with standby, and surgeons hardly ever standby in angioplasty. Similarly, in our field, it started that way. They hardly ever required any more. But for interdisciplinary care, what is the best thing to offer the patient? All these people are important. A pulmonary person, a thoracic surgeon, an anesthesiologist who handles those difficult cases we showed you, a radiologist which can help you to plan your strategy and look at your GPS, and a wonderful endoscopy suite which we've been very lucky to have with a very proactive administration who could see that this is something which was very relevant. There are very few sites in the country with such a program, understandably. I told you, when I left America, 3 programs, Harvard, Hopkins, and one third one. When now 30 programs. So similarly in our country, it takes time. We started with 2 or 3, now we have 6 or 7 in the country where we can do comprehensive airway diagnostic procedures, airway therapeutic procedures, and pleural procedures. It is challenging, it is something at the cutting edge, but it gives you a lot of impetus for what is to be done, how to progress. In medicine, chances are few that you can actually go in, do new stuff, change the nature of the field, and keep practicing and learning at the same time when it comes to cutting edge undiscovered areas. This is one of these fields which is still waiting in India to see its the light of complete day, so to say. Caution, I told you I'll be addressing that. These are high risk procedures. I showed you that. You're sharing a compromised airway in somebody who's going to die in 2 to 3 minutes with the anesthetic. So it's not easy. This can be life threatening, and that is why it has to be done in the right way. And that is why I leave two lines on the safety aspects of this. These words should be imprinted in your mind when it comes to procedures. The stakes are high, patient reserves are low. Time is limited, delay is death. Skills needed are considerable. We are turning physician mindsets into surgical mindsets by and large. Trained assistants, infrastructure. I cannot come not having all the scopes which it takes to keep my patient alive. And we started this. When I started in the country, in the center, I had only so much. I realized, no, if I'm going to do this in the right way, and it's not me, this is just put out there in everywhere where systems are followed, I need the right equipment, infrastructure, assistance, and skills. The field is underestimated and underappreciated, but it's coming of age. But truly, this statement is true of all developing fields. So was cardiac surgery, so was angioplasty, when it matured to a point that it has reached wonderful levels at this point. Why is this risky? I leave the young initiate with this particular thing. This has been picked up directly from article. Airway complications and difficulties can be compared to fighter pilots flying high-speed jets, military assault units, or firefighter teams. I put this line for a single reason. This is not something you can take lightly. You do it the right way, you will get outcomes. So it is high stakes, high need, but lovely outcomes when it comes to using a multidisciplinary responsible approach to try and address all these things. Why do we spend time with you guys to talk of safety? Because it's not that we come here to show you what is cavalier. It is not a shock and awe. It is about defining the field. It is about outlining the way it happened there. It's about telling you what can be done. It's also about telling you how to do it by and large. So I put this funny picture out there. It can be a rocky road, high-risk procedures in sick patients, as we said, and can leave the team with a few wrinkles. I think I have aged and balded over the last decade as we've tried to do this in the right way. And believe me, I have stories on stories we can tell how this has been challenging. But I can stand with confidence and tell you it's worked out very well. There is no death sitting on our heads, which we think could have been prevented. And I put this picture. You need a team. Nothing epitomizes teams like children. How selflessly they work, how they will work towards a single endpoint in the game. And that is the ethos which is required to put some of these things into place. And if this talk and this need and this sort of understanding cannot put us into trying to do something, we really have to look at ourselves. This is the state of our country. We are currently in the midst of a respiratory disease and, of course, tuberculosis epidemic. I told United States of America, pulmonary critical care heads the fellowship at this point. It will last for 5 years, I don't know, but it's that much of a requirement. And this phrase is what really struck me, and I put it out here, that when it comes to knowledge and understanding, either we can just look and walk away, or we can do something. Some drink deeply from the river of knowledge, others only gargle. It is up to us to imbibe, implement, and use all this knowledge, and it is our outlook to explore this further. So to conclude, we offer a lot. We offer better diagnostics in this field now, airway, mediastinum, parenchyma, a lot of therapeutics. I can't cover a lot of it, but I covered a decent amount to give you an idea. And we close loops. 90% of our practice, 95%, we are not dependent on sending them out. And believe it, patients love it when there is one provider team taking care of them. If you keep handing them over like a relay, they don't like it. And we used to do that before. Loops did not close. They felt abundant. Now from OPD to inpatient to procedure to intensive care to outpatient, one team takes care of you. Your problem is our problem. This is where this sort of care can help to regiment not only what you do in a big way, but also enhance satisfaction and outcomes. A paradigm shift in the management of these patients on diagnostic, therapeutic arenas. To reiterate, we've showed you what it is, and I leave you with this sentence. It's hot, cold, mechanical, and ultrasound. That defines our field in 4 words. We need to interface with others, and I made enough of a case how all aspects of chest medicine and oncology is where we are entering. No longer can we say I'm lung this and all. It's all ultimately interdisciplinary where you put your heads together. And I think you guys will see this era even more. To put all this into place is lovely to talk about, but needs infrastructure, resources, skills, experience, and economics. You can't do this in any areas where you don't have technology, and that is a limitation of what we all do when it comes to technology. But if you do this, you have a comprehensive approach which expands the scope of the field. That has been very, very exciting to redefine the whole spectrum in this last decade when it comes to doing all these things in the cases I have shown you. It defines the holistic model of service, at least when applied to this field, for both outcomes and satisfaction. And I always put this out there. If these guys could do it, look at our space program. It's lovely, basically. So in interventional pulmonology, we also continue to rise to the occasion. And in this last meeting which we had in our national meeting in the field, from 2008 to 18, as I said, the whole thing has been redefined in this country in a very encouraging way, and this cosmos is ours to explore. We started off as in infancy, now we're still in our childhood, but we've been given this laptop. Our Karnataka Chief Minister was handing them out recently, pre-election also, which basically epitomizes we have the technology, understanding, knowledge, it's all there. It's a question of which patient, how, and how it takes the field ahead and patient care ahead. Are we surprised when I say that basically 15 years? No, and I put this for both you guys, administrators, our deans, and me to think about. What is medical knowledge? I'm digressing for 1 minute and bear with me over there. Medical knowledge is going through a juggernaut right now, and this paper really opened my eyes also. It is estimated that the doubling time of medical knowledge in 1950 was 50 years. In 50 years, you would need to know enough that you can manage it, so to say. In 1980, it came down to 7 years, 2010, 3.5 years, 2020, 73 days. And we have struggled with it every day. We struggle to find good doctors who will keep up with medical knowledge. We struggle to find systems which will allow us to keep in touch. At the same time, patients read much more than us and come to us. So, human brain did not change. My brain did not improve. But knowledge kept on increasing. Expectations kept on increasing. Where do we stand with this by and large? And for you guys, this is the knowledge. Students who began medical school in 2010, about 3 doublings in knowledge will happen. So, imagine the colossal amount of work. And as I look at my daughter who wants to possibly even talk in medical school, I tell her, watch all this. Are you willing to put all this effort or no? And this statement was an eye-opener. What was learned in the first 3 years of medical school will be just 6% of what is known at the end of the decade from 2010 to 2020. And that is the way knowledge is going right now. So to close on another funny note, what we have done a lot is out of the box. And I changed the phrase to say necessity is the mother of innovation. And we showed you those innovative aspects which have also got published in world literature. It has trained us a lot. Interventional pulmonology is a prototype of that. It has trained us to explore new areas. It has trained us to integrate with other areas much better. It has made surgeons respect us. They never looked at us until we started to do procedures, and they think we are much more responsible now, to the point we can tell them that if you have a complication, I can probably help you with that also. And we've done all this in India. So the phrase was very popular. I don't know how popular it is now, make in India, but nevertheless, it is something which is close to our heart. And we end with a thanks to all our patients. All these have left memories. I think if I write a book, I can probably have more return for what I do than anything else. All of these have memories. These young people, this gentleman from Hyderabad only lives his life with a tube and is going to get married and gets his father-in-law for me to endorse that he has a life. This young girl who's sitting with a foreign body for 8 months before we take it out and give her a life back. This elderly gentleman who has a tube stuck for 1 year and we get rid of it using these techniques. And this elderly lady who had a supari stuck for 1 year before we took it out. Small examples, basically representing a sea of cases, which ultimately represents a field which has moved remarkably in line with what I was telling you, representing the whole gamut of medical knowledge which has increased. I end with this quote: perfection is not achieved completely by anyone in this world, but if you keep chasing perfection, somewhere on the way you may catch excellence. If you think of climbing Everest, you'll reach the nearest skyscraper and do a good job with what you do. Thank you very much.